in subsequent modules. So let me start, if I may, by asking you, what role do you think that you played, in general terms, in that core political decision-making in the period that you were in office during the pandemic?
Well, I think the main responsibilities that we had and I had were to do everything we could to ensure that the NHS was able to look after severely ill COVID patients and also all of the other non-COVID patients who needed our care during the course of the pandemic. So first and foremost, it was about the operation and the availability of the NHS. We were not directly asked to contribute to debates that government was having about lockdowns and so-called non-pharmaceutical interventions or other ways of controlling the spread of the virus.
Just pausing there a moment, Lord
Sure.
Stevens, if you can try and keep your answers relatively, speak relatively slowly and relatively short, that would help us all.
Okay, well, I'll stop there then.
All right. So you've described, in essence, most of your work, unsurprisingly, given what you've said, was on operational matters, helping the NHS deal with COVID and, of course, deal with all of the other things it would have been dealing with anyway.
Yeah, I think that's right.
And you've said that you were not routinely involved in those discussions about lockdowns and other MPIs. We can see, and you describe in your statement, perhaps we can look at paragraph 13 of your statement on page 5. You say that you did attend several of the COBRA meetings. We've heard about these meetings held in the early part of 2020.
Yes.
Several, all, maybe you can't remember now.
Probably almost all. I know the inquiry has the COBRA minutes, and whether I was there or not will be there, but certainly a number during February and then in March. But as I think I mentioned, in a sense, COBRA fell out of use as a mechanism by which the government decided to take its decisions or review progress against the pandemic. So that abated as a forum for this type of discussion. Well,
we've certainly heard that the COBRA meetings stopped, but are you saying that you stopped going to them for that reason?
No, I think I went to every COBRA meeting I was asked to go to, yeah, as far as I'm aware.
And was it routine that either you or someone else from NHS England was invited to those meetings?
During February 2020, I think that's right, and probably March as well. I mean, I'd have to literally go back and look at all of the COBRAs and the minutes and so forth, but that's my recollection, yes. You've
mentioned just now, and you describe in your statement, a view that these meetings were not, in your words, optimally effective. Can you expand on that?
Yes, my observation is that the COBRA meetings were very large, so lots of people, which often makes it hard to have very substantial discussions. And sometimes the seniority of representation ministerially at the COBRAs varied between departments. So it wasn't always the case that a minister necessarily had the full authority of their department when a discussion was taking place, was my observation. Now, others in government may take a different view.
There's a particular point you make, which we can see in this paragraph on the screen, Lord Stevens, which is that when, as we know they were in the early stage, the COBRA meetings were chaired by Matt Hancock, other Secretaries of State sometimes avoided attending and sent junior ministers instead. Was that a reflection you had at the time?
I'm not saying that was cause and effect, but that is the fact of the matter.
Well, I'm sorry. The inference in your statement is that it was cause and effect, but you're not going that far.
Well, I just observed that those two coincided.
Can you offer a view as to whether, in light of that, the phenomenon that you were observing, it would have been better for the Prime Minister to have chaired the COBRAs at the early stage? Would that have, do you think, ensured that more senior people, Secretaries of State, attended those meetings?
I think it's very likely that if the Prime Minister had chaired those COBRAs, then other Secretaries of State would have chosen to go as well. but whether the substance of those COBRA meetings was such that not having all of those folks there made a big difference, I defer to others.
Of course. Just following down the page, Lord Stevens, you indicate that you did attend some cabinet committees, and I think we can see, I'm not going to take you to the document, but you were an attender, were you not, of the MIG, the health? There was a particular health MIG early in 2020, which I think you did attend. Is that right?
Yeah, I think I went to several of them, but not all of them. And as I think I perhaps diplomatically say in my statement, I did not consider that they were the most effective forum for resolving operational questions, shall we say. And that's why, in fairly short order, they were abolished and replaced by a different system.
They were replaced by what I think everyone referred to as COVID-O, COVID-S, operational and strategy.
Yeah.
I think you're saying that your MIG was replaced essentially by COVID-O. Is that right?
I think all of the MIGs were, in a sense, replaced by COVID-O and COVID-S. The point being that I think having fragmented subject-specific ministerial groups didn't really deal with the cross-cutting issues, which actually were the main purpose of having those kinds of forums. And when it came specifically to figuring out things that required political involvement, a ministerial decision on health, the MIG was probably not the best place to get that done.
Did you attend either COVID-O or COVID-S, and did you find that they were more effective forums for the...
Yes, I did from time to time, and that was my assessment. And as I think I say as well, I think when the Cabinet Office created with number 10 this thing called the COVID Task Force, that substantially improved the coherence of what the central government was doing relative to individual government departments, was my impression.
You also say in your statement, Lord Stevens, that there were a few occasions at least where you had ad hoc meetings with the Prime Minister and other senior decision makers.
Yeah.
And I'd like to take you to a document which records one of those meetings. It's 146616, please. So this, Lord Stevens, is an email, is it not, dated the 10th of October 2020, so we're in the autumn of that year. And it's an email from Imran Shafi, who's given evidence to the inquiry, essentially recording a meeting which had happened, I think, earlier that week. And we can see from the start, the first line of the email, it was a meeting which included the Prime Minister, the Chancellor, Chris Whitty, Stuart Vallance, and you. And it may well be others as well.
Sure.
We don't see your name on the copy list. This appears to have been an internal sort of number 10 document. But I know you've had a chance to look at this document, and obviously if there are any things in it which don't accord with your recollection, you'll tell us. First of all, do you remember going to this meeting in the autumn of 2020? I say going. It may have been a virtual meeting.
Yeah, I do remember it. I think this note is the 10th of October. I think it relates to a meeting that Thursday. I think it was probably the 8th of October.
Right. And we see again from the first line that the purpose of the meeting was to discuss COVID, but perhaps in particular NHS preparedness. Preparedness for the winter to come?
Yeah. And in the light of rising COVID cases, which were apparent by early October.
And we'll look at just a little bit of the detail in a moment, but before we do, can you give us a sense of how frequent meetings like this were? Did you have meetings with the Prime Minister and the Chancellor weekly, monthly, less than that?
It ebbed and flowed. So during March 2020 and April, very frequently. Then as COVID numbers decreased and the pressures on the NHS likewise, then far fewer during May, June, July, August. But then from October, they increased again. And certainly by the time we were in, say, late December, early January 2020, very frequently. In fact, I think I had, between New Year's Day and the 10th of January, something like 6 separate meetings with the Prime Minister and others on both winter COVID pressures and the vaccine rollout. So that was the sort of pattern of it over the course of the pandemic. As I think I also say in my statement, Number 10 got into this sort of rhythm of having these so-called daily dashboard meetings at 9:15 that the Prime Minister would chair, and their frequency kind of changed a bit depending on what was happening with COVID. They could sometimes be every day, they could be 3 times a week, and I personally found those very useful sessions because it was a chance to kind of tell it straight, direct to the relevant senior politicians, and to the extent there were things that, frankly, I thought we could benefit from some support on, to sort of lodge that direct with the Prime Minister and others.
Just helping us to imagine what you're describing, Lord Stevens, can you just give us an indication of whether those meetings were virtual or not? I mean, were you spending your life going back and forth to Downing Street when you were having these regular meetings, or did you, for example, dial into those 9:15 meetings?
Yeah, some were virtual and some were face-to-face. So yeah, it was absolutely a mix of both.
We will come to the detail, but since you've given us that overview of your interplay, the exchanges you had, the meetings you had with the Prime Minister and his team, you are of course aware that we have heard evidence in the last few days, the last week or so, of difficulties in the decision-making process, a certain level of dysfunction. There's been evidence of the Prime Minister finding it difficult to settle on a particular decision. Oscillating is one of the words that's been used to describe that. Can you give us an overview of your experience of those months that you spent discussing COVID, helping him make those decisions?
Well, in a sense, I don't think I did help him make those decisions, if by those decisions you mean lockdown decisions, social restrictions, and so forth. So
just pause
I
there.
can't.
What I meant, because you have just given evidence that you had frequent meetings with the Prime Minister.
Sure.
At times very frequent.
Yeah.
I'm not suggesting that you were making the decisions with him.
Sure.
But one assumes that the purpose of him having those discussions with you was to help him make decisions. That's what I meant.
Yes, but actually the way the rhythm of it tended to work was we would have the session specifically on the NHS, and then ministers would go off and have a separate session without the NHS present, where then the consequences of that for their wider decision making would be taken account of. So I think a lot of what you've heard, as I understand it, over the last several days really relates to sessions that, frankly, I was not present at, so I can't give you good commentary on those.
You would, though, have experienced the consequences of his decisions, and you would have found yourself at the next meeting hearing that a decision you might have expected to have been taken either had or hadn't been taken. So is there really nothing that you can say about the way in which the decision-making process took place?
Well, I mean, obviously, I can see some of the evidence that you can see now as well, not all of which, obviously, we were privy to at the time. What I would say is that in respect of decisions that we needed from government on NHS capacity, I mean, sometimes decisions were taken which we didn't like, but nevertheless, those were the decisions. I think the best example, in a way, of the sort of interface with prime ministerial decision-making that I can personally speak to was around the rollout of the vaccine programme, where the Prime Minister was very personally involved in that. And for the most part, that was actually a constructive engagement on what needed to get done. And we can obviously talk specifically about that, but
Yes. All right, well, we won't, because as we said, there is another module to come, and I'm sure there'll be an opportunity for you to talk about vaccines in the vaccines module. Let's look, if we can, at this document, and it's perhaps the third paragraph, where we see that the PM asked about NHS capacity, and there's then a record of a relatively detailed review, if you like, that you conducted of the position as it stood regarding the NHS. We see reference to regional variation, and we also see in the first line that you stressed the NHS was not overwhelmed.
On the 8th of October 2020, correct.
Exactly, and so you are saying it wasn't overwhelmed at the time of the meeting, and then reading on, you describe the regional position and give some view about the future. And I'm going to come back to the question of NHS overwhelm shortly. But just looking a little bit further down the document, there's the next paragraph we see that the discussion turned to the question of MPIs. Simon Ridley, one of the Cabinet Office officials, gave a presentation about MPIs. Then there's another paragraph where it appears that you contributed to the debate, perhaps about MPIs. It says, Simon Stevens argued that, stepping back, not everyone currently accepted there was a problem. People did not think measures were fair. They questioned whether they worked, and if they did work, they wanted financial support. Government response should take these factors into account. So first of all, slightly contrary to what you said a moment ago, this does appear to suggest that you were contributing to discussions beyond simply the NHS capacity matters.
Well, I think on this occasion I was asked, what are people in the health service in Liverpool, Merseyside, the North West seeing about what's happening in their local situation? Because obviously part of my responsibilities were often to be out and about around the country talking directly to people who were affected. And I think in that comment I was reflecting what I had been told directly from people in Merseyside, Manchester and elsewhere, that frankly the set of mechanisms that were then supposedly in place in those areas were not working. And their view was that part of the problem was that there wasn't sufficient financial support for people who were being asked to self-isolate. And so when I was asked the question, I answered.
Yes, and in fact one of the themes of the evidence that we've heard is precisely on that issue, that there was a live question about whether sufficient financial support was being provided, including, in fact, to workers in the healthcare sector. And I think, are you saying that perhaps it was workers in the healthcare sector that you were reporting back on, as it were, needing further financial support?
You know, I can't remember that specifically, because obviously there were different arrangements for NHS staff, furlough and so forth. So I can't say that directly. But what I can say is that I think this was a time, as I recall it, when it was a pretty variegated set of local restrictions that were in place around the country. And frankly, a lot of people were struggling to understand the rationale and what they were supposed to be doing in one place or another. And I think it's the case that after this, the government then moved to their more sort of clear-cut tiering system to try and respond to that.
Quite. And on any view, you were voicing support for the idea that further financial support needed to be given to people self-isolating.
That was my personal view. I think actually what these notes show was that I was describing what I'd heard other people saying, but yes, that was also my personal view.
Thank you. I'm going to move away from this document, but stay, as it were, with that general issue of exchanges between you and the Prime Minister. And I'd like to go, if we can please, to the written witness statement of Helen MacNamara, which is 273841, paragraph 71. On page 39, I think. Yes. Lord Stevens, I don't know if you've had a chance to look at this document before. I hope you have.
Sorry, which part are you looking at?
Well, let me show you. One of the observations that Helen MacNamara makes in her witness statement, and in fact that she expanded on in evidence yesterday, is the last sort of 5 or 6 lines of this paragraph we're looking at. She, of course, is talking about her experience of dealing with officials and politicians in Number 10. But she said this: "I don't remember anyone working in the centre or who was part of the conversations who had a detailed understanding of the way the NHS operated. This is not unusual or unique." And she talks about the fact that social areas of policy are less well represented in Downing Street than military, national security type matters. Mm-hmm. Interested in your views on that, with your long experience of dealing with politicians, but perhaps particularly that period during the pandemic. Did you feel there was, as it were, a deficit in their understanding of the granular way in which the NHS works?
I think Helen's description seems to me accurate, particularly as regards the Cabinet Office. The extent to which the Prime Minister's Office, Number 10, has health expertise is to some extent a function of how the Prime Minister of the day chooses to staff their Number 10 policy unit. During the pandemic itself, I think there is truth in what she says, but to some extent, as long as that doesn't lead to ill-informed second-guessing of the decisions that people in the NHS are actually trying to take, that need not in itself be a problem.
One can certainly see how it would be a problem if there was that sort of second guessing, but surely even if they leave the operational decisions to you, it would still be necessary for them to have that level of detail in making the higher level decisions, for example, MPIs and so on.
Yeah, I think to some extent that is true. I mean, I think there was as I think Helen described, and I agree with her, there was a sort of disconnectedness between aspects of what the Cabinet Office was doing early on in the pandemic and what sort of we were seeing in terms of the operational realities. As I say, I think the COVID task force really helped with that, because that brought together people who had that more detailed set of expertise into one place with a single voice where you could have a direct conversation and know that the advice that would then go to the Prime Minister or others would be properly informed by what we were telling them. And just sticking with that then, we'll hear more about the COVID task force, in fact, in evidence next week. But right. Help us with this. Were there people, civil servants, involved with the task force who had this sort of granular understanding of the NHS in a way that perhaps the earlier structures didn't have? I think to a greater degree, yes. And there were some, even if there were some generalists, they, I think, pretty quickly understood the moving parts, shall we say.
I want to move to a slightly different topic, Lord Stevens, and it's still to do with your engagement with the Prime Minister and Mr. Hancock and others. But it's a rather basic question of whether Mr. Hancock in particular, but others, were encouraging you to resign or otherwise remove you from office during the period of the pandemic. I'll take you to some documents, but were they or not?
No.
Let's
not
look,
to my face, anyway.
Let's just look at a couple of WhatsApp messages, if we may. First of all, 129176. Let me say these are both these messages are from very early in the pandemic, but you can see January 2020. Dominic Cummings is texting to the owner of the cell phone, who is Mr. Hancock, saying, "Where are we with SS Simon Stevens?" He says, "It's in train. I'm first getting Ara Darzi to persuade him it's in his best interest to go now. If that doesn't work, I'll move directly." And then if we can go, please, to 129185. 10 days or so later, the 3rd of February, it's just at the top, Dominic Cummings says, "When SS off?" Matt Hancock says, "Wanted to talk to you about this in the margins of meeting tomorrow." Short answer is his initial proposal is to announce in September and go at Christmas. I haven't yet engaged. How hard to push for sooner? Dominic Cummings says, we must get on with it now. Announce next week as part of reshuffle frenzy, and then it will all get lost in that. Matt Hancock says, let me see if I can square him for that. If I can't, we can still go if we want. So at least on the basis of these messages, first of all, there certainly do seem to have been discussions between Mr. Hancock and Mr. Cummings about you leaving, and it does appear that Mr. Hancock had had some discussions with you about that.
Well, take a step back. I, as you said at the start, was appointed in 2014. When I took up post, I envisaged serving for around 5 years, which would have taken me to 2019. As you may recall, there was a degree of political chaos in the United Kingdom during the course of 2019, a change of Prime Minister, a general election, and I therefore did not feel it was quite the right moment to create a gap in the leadership of the NHS. So I think it was known that that was something that had been in my mind, but felt that I should stay through to the new year and then sort of make a decision at some point during the course of 2020. Now, of course, COVID then came along, and it would have been completely wrong to have left a vacuum during the first wave of COVID. Come summer 2020, the thought recurs, but I have a discussion with the Prime Minister about that during summer 2020. But by the time that possibility would crystallise, we were back into another wave of COVID. So I therefore, again, felt duty-bound to see the winter period through and then the rollout of the vaccine, at which point in July 2021, I was able to leave.
Yeah. Well,
but by the way, can I just say on some of these things, I think there's a suggestion there about asking Lord Darcy to persuade me. These emails, I think, have previously been leaked to the Daily Telegraph, and in response to those, Lord Darcy has said on the record that is not correct, and I think his actual word were that is misinformation. So he did not seek to persuade me in the way that's described here.
Well, thank you for clarifying that and for the earlier answer, Lord Stevens. And let me be clear, the reason that I'm asking these questions is to understand whether there was a relationship of confidence and trust between you doing your very important job and Matt Hancock, Boris Johnson and others during the period of the pandemic. And I think it follows...
Well, can I just say on that? I think it's relevant, as I saw Dominic Cummings' statement earlier in the week. I think he has said on the record that when the pandemic struck, he was then not seeking to do this. And I believe Matt Hancock has said the same in his written statement. So I have no insights other than what the two of them have said on the record.
And your evidence, putting those exchanges in context, is that there was no sense in which you were somehow defying them in staying in your role in January, February 2020.
No.
But I do want to ask you about one more message, which is from later in the year, August 2020. I'm not going to bring it up on screen, but let me just read it out. Its primary focus is Mr. Cummings coming back to the question of whether Mr. Hancock should leave his role, but he does mention you as well. He says this: I must stress that leaving Hancock in post is a big mistake. He's a proven liar who nobody believes or should believe on anything, and we face going into an autumn crisis with him in charge of the NHS still. Therefore, we'll be back around that cabinet table with him and Stevens bullshitting again in September. Hideous prospect. So, leaving aside the question of Mr. Hancock, did you, later on in 2020, in August, have the impression that Dominic Cummings or Boris Johnson was dissatisfied with the way that you were running the NHS or bullshitting them?
Well, by the standard of Dominic Cummings' adjectives, that's one of his gentler epithets. Look, what I would say is, well, I just said it a moment ago, actually, I did have a discussion with the Prime Minister in the summer of 2020 about whether or not I would be able to be released from active duty in the NHS. We discussed specifically whether I might play a role in helping improve social care in the country. To be frank about it, I was pretty clear-cut about what I thought success would look like if we were going to improve social care, that it needed to be not just about ensuring that people didn't have to sell their homes, but also that the availability of social care increased and that the social care workforce was addressed. I was clear that I didn't think this could be done just as a private Whitehall process, a sort of behind the bike sheds agreement between ministers. It had to be a public, open process. And ideally, if it was going to create a national consensus, so social care reform actually got done, it needed to be on a cross-party basis. That was the basis on which I suggested action was required. Those points did not find favour, and therefore I didn't do it.
Did you think that Boris Johnson, Dominic Cummings, trusted you to do your job during the summer and autumn of 2020?
I can't speak for Dominic Cummings, but there was nothing, because I had no conversations with Dominic about this question, but my regular interactions in the autumn with the Prime Minister did not give me a different sense of that, no.
And what about Mr. Hancock, Mr. Stevens? It is important to understand whether there was a fruitful relationship of trust between the two of you, that the inquiry has heard evidence that other people working with Mr. Hancock found him someone who was untruthful. Was that your experience or not?
There were occasional moments of tension and flashpoints, which is probably inevitable during the course of a 15-month plus pandemic. But look, I was brought up always to look for the best in people.
I'm sorry, Mr. Stevens, that's not an answer to my question.
Which question? Which bit of it?
Did you find Mr. Hancock to be truthful or not?
Well, I know various people have made quite strong accusations against Matt Hancock. All I would say is strong accusations need strong evidence to back them up, and I don't think I've seen that evidence.
I'm still not sure you're quite engaging with my question, Lord Stevens, and it is important because you were at the head of the NHS, he was at the head of the Department for Health and Social Care. In your working relationship with him during these most extreme and important of times, was he someone you found you personally could trust?
Yes, for the most part, yes.
What do you mean by for the most part, Lord Stevens?
Well, as I think I said right at the start, I'm not denying that there were a small handful of occasions during the course of the year and a half, when there were tensions. But that, I don't think, is particularly surprising given the circumstances under which everybody was working.
I'm going to move on to ask you some questions about something called Operation Nimbus. Let's look, first of all, at your statement, please. Paragraph 21, page 7. I think it's right to say you attended this operation, which was a tabletop training exercise.
Yes.
I'm not going to call it up, but we can note that it was an exercise that was implemented following a SAGE meeting, a COBRA meeting on the 29th of January. We could see it in the minutes that there needed to be an exercise. And as I think we've said, it occurred about 2 weeks later on the 12th of February 2020. Can you just describe in a few sentences, Lord Stevens, what that exercise was about and what you took from it?
Yes, the purpose of the exercise was to look at the so-called reasonable worst-case scenario, which I know the inquiry's heard evidence about, which is saying if it's the case that COVID turns out to have these features, maybe 81% of people are infected and a proportion of them then die, that obviously is a huge and devastating impact on the United Kingdom. What are the responses that different government departments need to make? And so I think it was less specifically aimed at the health response and more about having a broader range of Whitehall departments who had not been so involved in those conversations, kind of getting their head around, my goodness, this would be an absolutely terrible thing. What would we need to do to make sure our plans are prepared?
We haven't actually seen any report or summary from this exercise.
Right.
Do you happen to know whether such a document existed, or would you have expected such a document to exist?
Yeah, I would have assumed that the Cabinet Office relevant secretariat would have produced some sort of notes from that, actions for departments, whether they have or not, leave to you, but I would have thought so, yes. I mean, I might also say that, in a sense, the effectiveness of this exercise was slightly undermined by the fact that this took place on the 12th of February 2020, with a lot of ministers from a range of departments other than health around the table. And then the very next day, there was a cabinet ministerial reshuffle, and quite a number of them lost their jobs. So it was an entirely new set of ministers who had not been exposed to any of that 24 hours before.
I was going to ask you, without wanting to stretch your memory too much, in fact, who was there? Do you recall whether the Prime Minister was there?
I don't think he was. No, I don't think so. But I'm sure there will be records to that effect.
We haven't seen any, but we can carry on looking. But I think it's implicit in what you say then that certainly I think Mr. Hancock was there.
Yeah.
We'll come on to talk about that. And other junior ministerial people who, as you've said, some of whom may have lost their jobs or changed their jobs the next day.
Yeah.
Let's look at what we do have about Operation Nimbus, Lord Stevens, which is, if we can call up on screen, please, INQ 52022. This is a set of, I think, slides. It's perhaps a PowerPoint demonstration. It's perhaps what the participants in the operation were shown, or at least part of what they were shown. And if we can go to page 7, please, we see the synopsis, which is very much as you've already outlined. It is to be imagined that the COVID pandemic has advanced, as it were. We see that the participants are asked to imagine that the date is the 14th of April, excuse me, so 2 months further on from the 12th of February, which was the date this took place. Sustained transmission has been ongoing for a month and a half, hypothetically, by that stage. There are various facts and figures given, but the most striking one is in the last bullet point, which is that it is, as of the synopsis, to be assumed that there may be around 840,000 excess deaths over the 16-week wave of infection, which, as you say, reflects the reasonable worst-case scenario at the time. Is that fair?
Yes.
And then if we look over the page, and we see a wave, which was the scenario that was being engaged with. The sort of solid line is the hypothetical line up to the date of the exercise, and then there's a sort of projected dotted line after that. The wave lasts for 16 or so weeks, and the idea is that within that time there would have been that very large number, 840,000 excess deaths. Just a couple of points I want to ask you about leading on from that. The first is that, as you describe in your witness statement, this exercise seems to have provoked a discussion about who should be responsible for making decisions about prioritisation, allocation of stretched NHS resources in a situation like this. Perhaps we can take this down and look at paragraph 21 of your witness statement. It'll come up. It's on page 7. Sorry, perhaps I should have said that. So it's at the bottom of the page. So we can see, Lord Stevens, you say it, that is the exercise, did result in, to my mind at least, an unresolved but fundamental ethical debate about a scenario in which a rising number of COVID patients overwhelmed the ability of hospitals to look after them and other non-COVID patients. The Secretary of State, that's Mr. Hancock, took the position that in this situation, he, rather than, say, the medical profession or the public, should ultimately decide who should live and who should die. And then you say, fortunately, of course, that dilemma never actually crystallised. Just before I ask you about this, to note that, is it right that the previous Secretary of State, or possibly a previous Secretary of State, but Jeremy Hunt, had taken a different view of this matter, had he not? I think it was connected to exercise Cygnus, which had happened some years before. He had taken the view, and this is in fact something that he spoke about in evidence in Module 1 of this inquiry, that decisions of this type ought to be reserved to clinical staff. Is that something you're aware of?
Yes, I've heard Jeremy Hunt say that, yes.
So there you are. I mean, he took one view, and you're saying in your statement that on the 12th of February, Mr. Hancock took a very different view. Did you have a view as to whether that was an appropriate line for him to take, desirable or not?
I thought it would be highly undesirable other than in the most extreme circumstances, and you can argue that these are the most extreme circumstances, and that is one of the reasons why the Department of Health and Social Care, I think, created a ethical and moral advisory panel to sort of ask the question, you know, if absolute disaster strikes, then how would you ration care, limit it in a way that would be fairest and have the, you know, be the most defensible under this, you know, horrible situation. But I certainly wanted to discourage the idea that an individual Secretary of State, other than in the most exceptional circumstances, should be deciding how care would be provided. I felt that we are well served by the medical profession in consultation with patients to the greatest extent possible making those kinds of decisions.
And this, I suppose, was Operation Nimbus doing its job in the sense that it raised in advance an issue like this while there was still time to think about how to deal with it. And did you then take steps to at least pursue that debate as to whether Mr. Hancock should have that level of decision-making in a worst-case scenario?
Well, I think, and this is something that I think you're seeing Sir Chris Wormald from the Department of Health and Social Care later. That's probably something that Chris Wormald may be able to give you information on as well. As I say, the department had this moral and ethical advisory group, and I think they continued in existence during this period. So I actually don't think this was a question that was resolved. There were specific instances that gave rise to this type of question. At one point during the first wave, there was a group that had come up with essentially rationing criteria that might be used for critical care in the event that there were not enough critical care beds for severely ill patients. Our view was, my view was that actually by the time that was drawn up, it was clear it wasn't going to be needed. And in any event, it was far too crude a tool that would result in bad decisions being made around the country. So that was never promulgated.
I want to move to a second issue, sort of stemming from Operation Nimbus, Lord Stevens, which takes us back to this question of the NHS being overwhelmed. We know that a month later than Operation Nimbus, the 12th of February, we know that on the 13th of March or thereabouts, there was a change of policy from the mitigation strategy towards a suppression strategy, which in the end involved a lockdown. And we also know that one of, if not the key rationale for that change of policy was a fear of the NHS being overwhelmed unless the policy was changed. But we've also heard from a number of scientists who sat on SAGE, who, in summary, have said that it in fact was obvious or fairly likely or very likely to them that the NHS would be overwhelmed sometime before the 13th of March. And they, I mean, for example, Professor Medley, who I'm sure you know, the chair of SPI-M, said that throughout February it became increasingly clear that NHS capacity in the UK would be overwhelmed. And just looking at this Nimbus exercise, it's inherent in what we've been saying about decisions of life and death and so on, that the exercise that was run there had as part of its core a situation in which clearly the NHS would have been overwhelmed. So just drawing those strands together, from your perspective, was it as late as the 13th of March or thereabouts that it became obvious, and only then did it become obvious that the mitigation strategy would involve the NHS being overwhelmed? Or is it something, to your mind, that was apparent earlier, or at least should have been considered earlier?
I think it was clear that if the reasonable worst case scenario were to come about in the UK, then the NHS would be overwhelmed. And we had a group of our clinicians and analysts working, for example, intensely with the SPI-M modelers on Sunday, the 1st of March, to refine what the parameters might be for thinking about how many intensive care beds each sick patient might need and so forth. And that produced a set of scenarios that evening, Sunday the 2nd of March. SAGE papers, as I see them now, on the 3rd of March 2020, have two separate papers, one from Imperial, one from the London School of Hygiene and Tropical Medicine. SAGE on the 3rd of March says three things. It says it is highly likely there is sustained transmission of COVID-19 in the UK at present. Secondly, they say, given current surveillance systems, it will not be possible to time the start of interventions optimally. And third, they say, whatever the exact figure, NHS demand will greatly exceed supply in a reasonable worst-case scenario, even with behavioural interventions and behavioural and social interventions. So I think it is apparent that certainly by the beginning of March, it could be seen that if action was not taken to reduce the growth of COVID, then the NHS would be overwhelmed.
Thank you. And one of the issues that we are considering is whether advice from bodies like SAGE was clear enough, and maybe that your reference there to the minutes slightly makes the point that sometimes these messages can be confused. But what I really want to get to is your own view, not with hindsight, but at the time. And do I take it from what you've said then that, first of all, the 12th of February, so Operation Nimbus, although the exercise involved a set of facts which included the NHS being overwhelmed, are you saying that at that stage, because it was still then a worst-case scenario, it perhaps wouldn't be fair to say that at that point it was clear that in reality, really, the cards were on the table and the NHS was going to be overwhelmed at that stage?
Yeah, as you say, I want to be very careful of hindsight bias, but I think Nimbus was explicitly presented as a scenario, as a possibility, as an exercise. It was not being suggested by the epidemiologists or anybody else that this is the course we're on, so now plan against it. And I think I make the point in my written statement that one of my observations looking back is that there was too much ambiguity about what the status of this reasonable worst case scenario was during the course of February and the first part of March. And the probability that the reasonable worst case was actually going to become the case. Obviously, that probability evolved during the course of February and early March. But I think, for example, minutes of the COBRA meeting on the 29th of January say that, informally at least, it was thought there was a 90% probability that the reasonable worst case scenario would not come to pass. And then sort of a few days later, early February, I think it was said there was a 4/5 probability that it wouldn't come to pass. But I think one of the takeaways from this is that there needs to be much greater clarity about what is the probability that is being assigned to these different potentials, so that policymakers can understand what exactly they're being told.
I mean, one way of looking at it, and this is, I think it was Professor Woolhouse who said this, is that the point of having a reasonable worst case scenario is that that's what you should be preparing for. And so, in a sense, you leave aside the probability of that situation eventuating, you just prepare for it. But I think perhaps your point is that that might be a slightly it's too difficult to achieve that situation in real life. People are always going to want to know how likely it is that this sort of terrible event is going to happen.
I make the point, I think, elsewhere in my statement, that the government obviously has has a national risk register, and there are all sorts of reasonable worst case scenarios in that. If we were actually to act on all of those, i.e. give them a probability that on the balance of likelihood they're going to come about, then, life would grind to a halt. So at some point when these national risks begin to crystallise, you have to be clear as to whether you've moved from a purely theoretical possibility to this thing is happening, do something.
Let me move the conversation on, Lord Stevens, but sticking with this question of NHS overwhelm just for a few more minutes. We've been focusing on March 2020, but it's right, isn't it, that the later lockdowns towards the end of 2020 and then into 2021 were also triggered, amongst other things, by a concern that without it, the NHS would again be overwhelmed. Of course, then, much more water had flown under more bridges. Do you think that later in the pandemic there was a clear sense amongst decision makers of what NHS overwhelm actually meant?
Yes, in the sense of, look, I mean, if you're confronted with a situation where you have, say, 100,000 hospital beds in England, and you're being told that if the pandemic runs out of control, you might need between 200,000 and 800,000, then, that's orders of magnitude above what can be created. You cannot clone a new NHS in 8 to 12 weeks, and you certainly can't clone 7 of them. And by the way, nor can any other country, and the same exact issues were being confronted in France and Germany and Spain in winter 2021 as well. So that's, I think, the sort of first point to make. The second point to make, though, is that by the time we got to autumn 2020, actually, we obviously knew a lot more about the virus. Hospitals had done a lot of work to create the ability to turn on so-called surge capacity, extra critical care or other beds as cases rose. And we had new treatments for COVID and so forth. So taking, as it were, England as the unit of analysis and saying just is the NHS overwhelmed or not overwhelmed in a binary way kind of misses the point, because actually you have a graduated set of negative impacts as COVID pressures increase on the NHS. But I would make another point as well, which is that I personally do not think solely viewing the amount of COVID through the lens of whether or not there are NHS beds to cope for severely ill patients is by itself the right lens, because even with unlimited hospital capacity, if you have large amounts of coronavirus for vulnerable people, lots of people will still die. So the right question is, how do you control the increase in the numbers infected, not just how do you match the number of people who are going to be very, very ill to the number of hospital beds?
Thank you. And as you say, that's a point which you develop in your witness statement, and it's what I wanted to ask you about, which is, did you feel that taking the risk of NHS being overwhelmed as, if you like, the switch, the trigger for lockdowns was the right approach for the government to take?
Well, it was clearly highly desirable to avoid a situation where ill patients weren't able to get the healthcare that they would benefit from, and we did, I think, for the most part, achieve that. But by itself, that, if you're interested in saving lives, is not the only goal.
Let me take you, please, to a different issue, and it is the question of the discharge of patients from hospitals into the community, into care homes in March 2020. Now, as you know, that's a set of issues which has already been, amongst other things, subject to litigation, and it will also be addressed in a module of this inquiry. So I don't want to go into it in any detail, but there is one issue that is raised in Mr. Johnson's witness statement for this module, and which you touch on as well. And so I'd like to address that, please. And can we do it by going to Mr. Johnson's witness statement? Excellent, we have it on the screen. And it's paragraphs 330 to 331. So starting at the bottom of the page, we see that Mr. Johnson notes that on the 17th of March Cabinet meeting, there was a note that over 30,000 patients were imminently expected to be discharged from hospital and into social care. If we can go over the page.
Yeah, just to clarify, it wasn't that number. I wasn't at that meeting, but I do see that the full Cabinet did discuss that question before the policy was announced, yes, on the 17th of March.
This is really just setting up Lord Stevens, Mr. Johnson's evidence, and then I'm going to ask you about it. So he describes, as we can see, on the 22nd of March being provided with a copy of a DHSC document, COVID-19 response was discussed. There was an estimate in that document that between 12,500 and 15,000 hospital beds could be freed by postponing non-urgent elective operations, and that potentially 15,000 further acute beds were being occupied by patients awaiting discharge or with lengths of stay over 21 days.
Can I just clarify one point, sorry? Although that may well have been in the Department of Health and Social Care's draft on the 22nd of March, that information had already been presented to and discussed with the Prime Minister on the 12th of March.
Yeah, I'm not. It's a quite a high level point I want to take you to, okay, Stephen. So don't worry too much about the chronology or the dates, or the numbers. If we can go to the next paragraph, please. It's really, this is the core of it. Mr. Johnson's position, he says it was very frustrating to think that we were being forced to extreme measures to lock down the country and protect the NHS, as we've said, protect it from an overwhelm, because the NHS and social services had failed to grip the decades-old problem of delayed discharges, he says, commonly known as bed blocking. And he says that before the pandemic began, he was trying to address that. Now, that's the point, right. Whether, if you like, I think as Mr. Johnson might say, he'd been painted into a corner of having to have a lockdown in part because of the people he describes as bed blockers. And that's something that you address in your witness statement, and perhaps we can go to that, please, on page 12 and footnote 9. We really will have to expand
reading
it,
spectacles at this point. Yes.
I mean, Lord Stevens, this is the part of your statement where you address that assertion.
Yeah.
And in summary, you don't accept it. Let's not read that out. Can you tell us in your own words what your response to Mr. Johnson's line is?
Well, I think Boris Johnson is right to point to the fact that there have been long-standing problems with the availability of social care that has often meant that patients end up stuck in hospital when they could be being looked after at home. That is, without a doubt, correct. However, if you think about his suggestion just a moment, even if you accept that there were 30,000 hospital beds full in that way, which I think is certainly at the high end of what most people would estimate, but even if you think it's 30,000, we, and indeed he, were being told that if action was not taken on reducing the spread of coronavirus, there wouldn't be 30,000 hospital inpatients. There would be maybe 200,000 or 800,000 hospital inpatients. So you can't say that you would be able to deal with 200,000 or 800,000 inpatients by reference to 30,000 blocked beds. So I don't think the maths works. I mean, another way of saying it is, even if all of those 30,000 beds were freed up, for every one coronavirus patient who was then admitted to that bed, there would be another 5 patients who needed that care but weren't able to get it. So, no, I don't think that is a fair statement describing the decision calculus for the first wave. And, by the way, I think when you look at the second wave, when actually a lot of these problems have been addressed by the Treasury funding a lot more community health services and social care, getting rid of the means testing. So, in a sense, that problem had been significantly addressed. The Prime Minister still decided to have second and third lockdowns with this problem having been substantially resolved. So for both reasons, I think that is that suggestion doesn't stand up to scrutiny.
Thank you. Another issue, please, and this time it's a question about PPE.
I think I'm guessing that I'm being asked to take a break now.
Lady Sedley.
I hope you're warned, Lord Stevens, that we take regular breaks. I shall return at 25 past. Mr O'Connor.
Lord Stevens, I want finally to ask you a set of questions about PPE. I think I may have said that right before the break, with the same caveat as the questions about the discharge of patients in March, in the sense that, of course, detailed issues about PPE will be covered in another module. But this just picks up on some evidence that Helen MacNamara gave yesterday. And so if we could go to Helen MacNamara's statement, please, 273841, page 53, paragraph 104. When it comes up on screen, Lord Stevens, we will see that this is a part of Ms MacNamara's statement where she is describing various initiatives she took in the early months of the pandemic to try and effect certain changes or encourage issues to be addressed. And we will see about halfway down this paragraph, one of those issues that she became concerned about related to what she describes as the inadequacies of PPE for women. And she says she tried to make sure this was taken into account in any new supply. She gave evidence about that orally yesterday, and we looked at an internal email in which she raised this issue in mid-April with Simon Ridley and Mary Jones within the Cabinet Office, and that she was then told by another official within Downing Street, Cleo Watson, on the 30th of April, that the matter had been raised. And her evidence, as you can see, is that it was the Prime Minister who raised this issue with you on the April the 30th, 2020, and that you reassured the Prime Minister and ministers that the issues with PPE fitting women's bodies were misreported and that there wasn't a problem. Do you recall that?
Well, first of all, Helen was absolutely right to raise this issue because there were real concerns and we were very concerned about it and we were taking action. So she raised it within the Cabinet Office, as you say. As it happens, we were already acting, and in fact a week before this meeting, the Chief Nursing Officer, the National Medical Director for the NHS had written to every head of nursing, every medical director, every chief executive in the country on this very issue of fit testing to make sure that it was being done properly and that the issues that Helen describes were taken into account. So it certainly wasn't something that took the Prime Minister on the 30th of April to raise. It was already being specifically addressed and we were very concerned about it. As to the specific, as to my remarks in the meeting, I think I take it from what Helen said that she wasn't at the session itself. So that's not what I actually said. And if we could pull up the minutes of the meeting, then I think that will show itself. So it's actually INQ 88643 on page 7.
Sorry to interrupt you,
right.
But so as far as I'm aware, we haven't.
It's on your system. Can I just at least read it then, even if you're not going to put it on the
that's
screen?
what I was going to suggest.
Okay. So actually, the Cabinet Office's own minutes of that meeting say, first of all, that the Permanent Secretary at the Department of Health and Social Care responded on the availability of PPE, given that the Department of Health and Social Care has responsibility for securing PPE for the NHS. And then it goes on to say, the Chief Executive of the National Health Service said, there was ongoing work to investigate the suitability of PPE for all those using it and testing to make sure it was suitable for women, for those who are black, Asian, and from minority ethnic backgrounds, and those with different face shapes or facial hair. So I think the Cabinet Office's own records show that what is attributed to me secondhand is not actually what I said at the meeting.
Right. Well, that's very helpful. And so the answer that you gave to the Prime Minister was perhaps a holding response, saying that there was a problem, but that you were looking into it.
Yes, and the minutes of the meeting as well from the Cabinet Office set a specific action, which was that the Department of Health and Social Care should confirm that PPE had been procured and was fit for purpose for staff in response to reports that gowns did not fasten as they were too small and that certain items did not fit women. So this was specifically being addressed.
And what we know, and we can see in other evidence, is that in fact this issue of misfitting PPE continued to be a problem for weeks, months, even years afterwards, didn't it, Lord Stevens?
I don't know about years, but it definitely was a problem as a result of the short supply of PPE overall, with the result that it was often very difficult for DHSC to get sufficient range of masks in different locations at the right time. There's no doubt about that.
Well, just finally, let's look at one last document, which is INQ 97875. A letter written by the BMA to the Chief Executive of Public Health England, so to be clear, not either you or your organisation, but dated January 2021, not quite a year after that meeting. And if we can go to the second page, please. We see the last substantive paragraph. We have written separately to DHSC to raise concerns about PPE failing to meet the diverse needs of the medical workforce, in particular that many female doctors have reported struggling to find respirator masks that pass fit testing. So the message that you had given to the Prime Minister that this was being looked at, I think that's a fair summary of the minutes.
Well, not just looked at, that action was being taken to try and resolve the problem, given the pressures on the supply of PPE, yes.
And was action still being taken to try and resolve the problem all those months later in January 2021, Lord Stevens?
Well, as you say, that was not a letter I don't think I saw because it was sent to Public Health England. And I think the specific point that Dr. Nagpal is raising in that letter is whether or not there should be a change in the rules or the recommendations for what type of PPE should be being worn. I think he specifically says that in the letter. And I'm sure the reason this was addressed to Public Health England is they set those rules and then everybody else sought to follow them.
Yes, thank you very much, Lord Stevens. Thank you, my lady. There are some questions to be asked by core participants.
Thank you. Mr. Wetherby.
Thank you very much. Lord Stevens, I am going to ask you questions about that final topic on behalf of the COVID Bereaved Families for Justice UK.
Yep.
And just picking up on that, your answer to Mr. O'Connor regarding the lack of appropriate fitting PPE for women, but also for people from black and ethnic minority workforce, is that by the time it's raised with you, there's ongoing work. Is that right?
Well, I think, yes, essentially, yeah.
Yeah, okay. So there's two issues here. First of all, in January and February of 2020, NHS England did a stock take, I think, of PPE. Is that right?
No, I think that was Public Health England and the Department of Health and Social Care, because Public Health England was responsible for creating and overseeing the PPE stockpile that supposedly would be sufficient if a pandemic struck. And as we all now know, it wasn't.
It wasn't sufficient. So
Correct.
And as the Chief Executive, NHS England, that would be a major concern to you and of great relevance, whoever did the stock taking.
Absolutely.
Yeah. So that's sufficiency. So first of all, it's insufficient. But this point about fitting face masks and also training to use PPE is a further important point, isn't it?
Yes.
There's sufficiency on the one hand, but also even if you have lots of it, if it doesn't fit or if your staff don't know how to use it, then that's an additional problem.
It is, although the 2 points are somewhat related in that if you can't be certain of getting the same type of face mask or PPE with each delivery because there's a shortage, then that is probably one of the root causes of the problems that I think you're describing.
Yes. So if you know about the problem in advance, then the sufficiency of different types of PPE should be catered for.
Absolutely.
Yeah.
Now, of course, as you know, what was actually happening at this time was there was a worldwide scramble for PPE, given that the
Yes.
UK stockpile was not sufficient.
Yes.
And the Department of Health and Social Care, the Cabinet Office, Department of International Trade went on a huge buying spree to try and secure us
Yes.
the PPE we needed.
So at this point, the stable door was open and the position was trying to be recovered.
Yes.
And it was difficult because there wasn't PPE available, even if you knew what you needed.
Yes, I mean, I think the national position and the National Audit Office looked at this, and I think their conclusion was that no individual item had a national stock out.
Yes.
But I think that's only part of the story, because obviously if you're really up against it, then the ability to get PPE to where it's needed at the right time for the right person is much harder.
Yes, and the management of it is something that no doubt the inquiry will be going into, as Mr O'Connor indicated in a future module, but an important point. But it's right, I think, that in 2016, NERVTAG had made a formal recommendation to the Department of Health that there should be a rolling NHS programme for the fit testing of respirators, FFP3 masks, effectively as an important part of infection control. That's right, isn't it?
I'd need to see the NERVTAG papers. I'm not disputing that, but I need to see them, yeah.
As the Chief Executive of NHS, this is something directly relevant to you. Let me put it up on the screen, and hopefully that will jog your memory. 22737, please. And as you can see, the heading of it, NERVTAG subcommittee on the pandemic influenza. So directly related to pandemics and face masks and respirator stockpile. And then formal recommendations to the Department of Health. And then I'll try and deal with this quickly, but if we can go to page 2. I'm so sorry. It's the bottom of page 1 and then 2. Have you got that? So under discussion points and stockpile, fit testing in the face of an emerging pandemic is a major challenge. And then going over the page, the point I'm trying to get to is the first bullet point. Just-in-time fit testing was proposed. However, there may not be sufficient time to put this in place between pandemic virus emergence and the first UK impact. It was agreed that there's no substitute for a rolling programme of fit testing in NHS trusts during inter-pandemic periods. There should be a caveat about fit testing and any recommendations. Okay? Does that help you in terms of the knowledge about this?
Well, I mean, this is the first time I've seen this document, but yes, I can read what you've put up there.
But you were Chief Executive from 2014.
Sure, but this was a document, I think, to Public Health England,
yes.
The Department of Health and Social Care, wasn't it?
Fully take that point.
Sure.
It directly relates to the NHS. It's a recommendation that the fit testing rolling programme should take place across the NHS, and you're the Chief Executive.
Yeah, and it may well be, but I do not want to give you an answer that is not fact-based. I can certainly ask that question and make sure you get that answer. But clearly, if just really skimming this document now, seeing it for the first time, it appears to be suggesting that fit testing was obviously specifically confined to intensive care units. The issue with COVID was obviously that it was a much wider set of requirements. And frankly, the pandemic planning for influenza flu was wide of the mark for the sort of PPE requirements that COVID brought about.
Yes, Lord Stevens, this is a document related to pandemic flu. It's related to PPE. It's related to a recommendation for a rolling programme across the NHS.
Sure, but
did you know about that recommendation or the issue?
And I didn't know about that specific recommendation.
Yes.
But just to be clear,
equipped is a ministerial priority within the Scottish Fire Rescue Framework 2022. The Scottish Fire and Rescue Service has a dedicated Assistant Chief Officer with responsibility for training to ensure this strategic priority is properly addressed. Some aspects of training fell behind as a result of the COVID restrictions, but the service is addressing that backlog as a priority. His Majesty's Fire Service Inspectorate in Scotland carries out independent inspection of fire service activity, and training is already examined as part of the HMFSI Service Delivery Area Inspection Programme. The East Service Delivery Area Inspection Report was published on the 19th of October, and the service will be taking forward all the recommendations contained in the report.
Katie Clark.
Minister agree with me that the Firestorm report makes alarming reading, and that the failure to provide safe systems to enable firefighters to decontaminate is a failure of the employers to provide a duty of care to their workforce.
Minister.
Thank you, Presiding Officer. The safety and well-being of firefighters is a priority for both the Scottish Government and the Fire Service. SFRS continue to make progress with its contamination working group, and I was pleased that we were able to recently provide £56,000 contribution to allow Scottish firefighters to be part of the current health screening trials.
Question number 3, Russell Finlay.
Thank you. I ask the Scottish Government whether it will provide an update on the transition of HMP Kilmarnock into public ownership.
Cabinet Secretary Angela Constance.
Presiding Officer, I saw first-hand when I visited HMP Kilmarnock in August work on its transition into public ownership, and operation is progressing well and on track for handover to the Scottish Prison Service on the 17th of March next year. The Scottish Prison Service has been working closely with Kilmarnock Prison Services Limited and Serco, the private operator, to deliver a smooth transition in a way that not only supports staff and those in custody, but maintains the high standards already set within the prison.
Russell Finlay.
Yeah, thank you. I also visited the prison last week and asked the staff if they backed the transfer. None did. I asked if they knew why it was happening. None of them did. I asked if they knew how it would happen. None of them did. Humza Yousaf is transferring HMP Kilmarnock for blindly ideological reasons. He doesn't actually care that it's an effective, efficient and well-run prison. The SNP transfer will even result in staff losing the protection of body-worn cameras which will be sent to English prisons. Will the Cabinet Secretary reverse this dangerous decision and commit to providing cameras to all prison officers across Scotland?
Cabinet Secretary.
Presiding Officer, the contract with Serco was due to come to an end, and this Government has always believed that our prisons should be owned and operated within the public sector, and that, presiding officer, is in the interest of public safety and not private profit.